under the care for immunotherapy, cancer therapy for 40 years, survivor. And now she needs chemotherapy.
Right.
But they found that she had critical AS, critical, not severe, critical.
Right.
So it means that the valve area is less than 0.5. It was 0.4 square centimeters. The velocities are very high. 5.74 because we repeat the echo. I couldn't believe it. It was extremely high. They did the whole workup. As a matter of fact, they were ready to do. They had on the schedule for TAVR.
Right.
On Thursday last week, not the last week, the past week, the week before, and then when they discussed the case in their TAVR meeting, they found, reviewing all the images, that she had a very high risk of having left coronary occlusion.
Right.
If you have left coronary occlusion during a TAVR, the mortality is 100%.
Wow. Jeez. I knew it was high risk, but not that high risk. Jeez.
No, extreme high risk.
Okay.
So and if you know it in advance, because you have all the imaging, the CT, what we do is we measure how the valve is going to look. It's called when the CT, we put a valve in, so how it's going to look, the distance between the valve and the ostium of the coronaries. It has a specific name, BTC, all that stuff, and you can predict which is going to occlude, and the distance from the annulus of the valve,
right,
to the takeoff of the coronary. If the length is less than 10, and then you measure the leaflet. When you put the new valve, the leaflet is going to go up.
Right.
So the leaflet, the length of the leaflet is important, because in this case it was 11 millimeters, and the valve was at 8.5 millimeters. So that it's going to occlude for sure.
Right.
That is called predictive coronary sinus occlusion. So if you know that in advance, what can you do to prevent it? So there's two things you can do. No, three things. Number one, don't do it. Don't do the TAVR, which was not an acceptable situation in her case, because she couldn't get chemotherapy. She was going to die. And this is a totally functional lady. She wanted to live. She's been fighting cancer for 4 years. Second, put stents and make a chimney. It's called chimney. You put a bunch of stents from the ostium all the way out into the struts of the new valve.
Right.
And by doing that, you make a new channel, a new ostium of the left main. The problem with that is that it has a very high incidence of occlusion and thrombosis, with a mortality at 1 month about 30%. 20 to 30%.
That would be in addition to the TAVR, the stent.
You have to do that in a stent. So you preempt it, put the stent. In this particular patient, that was not a good option, because, number one, chances of thrombosis are very high. And number two, she already had anemia and thrombocytopenia. The platelet counts were very, very low.
Okay.
So using antiplatelet agents on this patient was something that was very dangerous.
Okay.
So when they realized all that, they said, this is extremely high risk, we can't do it. So I got a call from the structuralist over there, Dr. Tammy, and he said, Ramon, we have this problem. Can you help us? And I said, well, yeah, I will do the procedure that we did. I said, this is the best thing for her. So that's what we had. That's what the patient was transferred to us.
Now, Dr. Tammy is from Memorial Health, right?
Yes.
Okay. And because you had the experience with Basilica and structural heart and these issues, and I mean, we are considered sort of a center of expertise in that area, correct?
Right, because it's a tertiary referral.
Right.
Yes, because we have the experience. The name Basilica, it means from, I'm going to spell it for you.
No, I know it. I wrote about it. I wrote about it.
Bioprosthetic, A, or native, L, S is scallop, I, intentional, L, laceration, to prevent coronary artery obstruction. That is Basilica. So it could be in bioprosthesis,
right,
or it could be in native.
Right.
95% of the time, 99% of the time, is being done in bioprosthesis,
Right.
not in natives.
Right.
For us, this was our first. In Florida, there are very few. In the country, there have been very few done in natives. And the reason why it's so rare in natives is because it's very difficult. Imaging is a problem. And also the leaflets are very, very thin.
Right.
The bioprosthetic leaflets are thick. So you can allows the electrification, and there's less chance that you're going to tear the leaflet apart when you're doing all this stuff. So there were several features that make this case complex. Not only that, the platelet count at the time of the procedure was 17,000.
Right.
The hemoglobin was low. I think it was 7 or 8. So it was an extremely high risk patient, to the point that we decided with the team and Dr. Moreno to do an exposure of the left femoral artery instead of doing percutaneously, so we could have better control of when we put the large catheter in the femoral artery. What we usually do is we close on this using a percutaneous technique to close the access site. But in this particular case, we needed to have control, and thank God that we did it. I found it out. I thought I didn't want to do it, but really, thank God, we made the right decision doing it exposure.
Okay.
So once we did the Basilica procedure successfully, so we lacerate the leaflet. Think of a leaflet like this. You make this is the leaflet, right?
Right.
So we cut it in the middle, and you make like a triangle, open, and then the ostium of the coronary is here. So you have flow through the coronary. That's what it basically is. So once we did the Basilica, then putting the valve was the simple part of the whole procedure. So it was a very successful procedure, and now the patient is ready to receive her chemotherapy. We're debating who's going to do it. If the patient going to go back to the Memorial Oncology team,
or MCI.
And that's a decision that they're trying to make among themselves with our oncology people, with the oncology people over there. And from our perspective, she's ready to go one way or the other.
Yeah, one way, either at MCI or up there. It doesn't matter. I mean, for your
that
ready.
Is the thing. Wise, we're done.
Now, for the layman, for the average person out there, can you explain native versus bioprosthesis in terms of this procedure?
Native is the valve that God gave us.
Okay.
That's what we call it, native.
Got it.
Bioprosthesis is a valve that is handmade. It's not handmade. It's man-made.
Okay.
And usually it could be bioprosthetic. In this case, it could be from cows, bovine.
Right.
From pigs. Porcine, or it could be metallic.
Okay.
With no but the metallic valve, we can't do this stuff. Okay. It has to be a bioprosthetic valve or a native.
But she underwent TAVR as well.
She underwent TAVR, of course. But to get the TAVR safely,
okay, you
have to have a laceration of the cusp.
Right.
So you can open the coronary sinus, and you don't obstruct the coronary artery. Because if you do the TAVR and you obstruct the coronary artery, she dies right there on the table.
This was not a valve-in-valve procedure. She didn't have the
no,
TAVR
that's
done.
Exactly the difference. Okay. What you've been reading is the valve-in-valve, but Basilica valve-in-valve,
right,
which is the most usual one.
Okay, that's why.
This isn't a native. Okay. This isn't your own valve.
Got it.
That's what makes it unique.
Great, and that's what I needed to explain, because I know I wrote about Basilica in December.
Yes.
Remember, and we explained that.
It's valve-in-valve. It's very unique. Very few cases like this.
Like this one.
And also in a very sick patient.
That's the other thing. Did she have this the EAS or from the artery stenosis from years ago? Did she have a heart disease?
No, she's young. She's young. So she had what we call bicuspid aortic valve. So instead of having 3 cusps, she was born with 2.
I got it. Okay.
And those are the patients who develop severe aortic stenosis at a younger age.
Okay.
And usually in the 50s and 60s, like this lady.
And was she diagnosed previously with that? Or
she was diagnosed recently with this.
Okay. All right.
But this she had for a long time. But this time she became symptomatic. She was in heart failure and all that stuff because of the valve. Even though the pump is normal.
So she became symptomatic on this because of the treatment, I guess, the chemo and all that. Or
she became symptomatic of the valve,
okay,
and at the same time she has more metastatic disease, or they were going to do chemotherapy. By doing chemotherapy, they always do an echo
okay,
because the chemotherapy is cardiotoxic.
okay, got it.
So when they did the echo, they found out that she has severe aortic stenosis,
Okay,
critical aortic stenosis.
and so that's what prompted the referral.
That's
because,
what prompted the whole thing. And then they said they evaluated. They said, yeah, we need to put a valve.
Right.
We need to do TAVR. And then when they evaluated, they said, well, we can't do the TAVR because now we have to do this. And we don't feel comfortable doing this. This patient is too sick.
right,
This patient is too sick. Send her to palliation.
right,
That was the recommendation of the heart team. So the doctor who's taking care of her said, no, this is a very functional lady. How can I send her to palliation, for God's sake?
no,
She wants to live.
right,
And the reason she's not getting chemotherapy is because he has this thing.
right.
I have to find a solution. So the doctor is when we get a call and we said, yes, I think we can help you. Our plan is to do this, this, and that.
Dr. Guerrero, what is palliation?
Oh, palliation.
Oh, like palliative care?
Yeah, palliative care. Yeah,
They said, no, we're not going to touch it. You send it to palliative care and forget about it.
they were giving up on her, basically, I guess.
Yes, we're giving up, and she'll be there in 6 months.
And
But the oncologist felt very strongly that they could help this lady, and the patient wanted to live. She's been a fighter. She's been fighting this cancer for 4 years. And if you see her, you wouldn't say that she has cancer. Actually, she looks good.
I mean, she's very young. I mean, 62 is.
She's young. So when they call us, I call my team here, and we have a discussion before I accept the patient. I have a discussion with some of my colleagues here. And we had a brief meeting. I said, this is the case. It's a very complex case, high mortality case, right? No matter what we do, are we willing to take it? And I said, I am willing to take it because I think we can help. We're here to help. So they say, go ahead. Let's see what we can do. So they have, the consensus was, let's do it.
Right.
Bring it over. And when she came in, we evaluated and we measured everything. We did all the decisions and said, this is the plan. So we went in with a plan, and thank God we have plan A and plan B. So the plan A is what we did. Plan B, we didn't do the chimney thing with the stents and all the stuff.
Right.
But thank God the plan A worked.
Great. And you said she was diagnosed 4 years ago with cancer. Is that right? Or,
yes.
do you know if she went through radiation or other kind of treatments in those times?
She went through everything. So the specific of the cancer therapy, I don't know. But it's a problem. I know in past medical history and stuff like that. But
okay, no. But during the chemo,
I really was not paying attention to it.
But during the chemo is when this came up in terms of her the echo.
She had immunotherapy before. Yeah. They have a big cancer program over there too. So they did all the stuff that they do for cancer.
Right.
But to chemotherapy, but they didn't know that she had this other problem.
Did she? And I'm sorry. What symptoms did she display regarding her heart problem? Do you know in terms during the chemo?
Shortness of breath. Heart failure.
Okay.
With the normal left ventricular function, the coronary arteries are also normal. Not normal, they're plaque nothing that is severely obstructed.
Well, it's amazing with her with the chemo she was going through that she was able to even make. I don't know.
No, because
she's strong.
she went. Her heart is normal. Her heart. This is a mechanical problem.
Right.
It requires a mechanical solution. There's no pills that are going to get rid of this thing. It's deadly. It's worse than cancer. This thing, once you have symptoms, will kill you in 6 months. So she didn't have severe AS. She had critical AS.
Right. And this is left. You're talking about the left main occlusion, which is that's the highest risk there is.
The higher risk for her was the left main occlusion.
Right. Right.
Because her anatomy.
Right.
So the TAVR was a very high risk for several reasons. Number one, she is not a surgical candidate.
Right.
Okay, I don't have a bailout.
Right.
We cannot open the chest and now we're going to do it surgically. We didn't have that option. And a young woman. She has multiple comorbidities. The anemia and the thrombocytopenia and the cancer were all telling us that she was not a good candidate. Okay, was bad risk. And the second, the anatomy, was extreme high risk.
Right.
Because the anatomy was predicting 100% occlusion of the left main if we would have done the conventional tower. So we need to before the tower, make sure that we were not going to occlude the left main coronary.
You're talking about the simulation or what with that
Right,
you
we do. Yes, we do. We on CT we have a program that we put how the valve is going to look. We do measurements, and we know that the valve is going to occlude or not.
Okay, that's a interesting technology there as well. Yeah.
Yeah.
Okay, great. Anything else? I mean, I guess we're waiting to hear from her, right, Carmen, in terms of getting the. Are we going to be able to talk to her?
Oh,
or
I
no?
don't have the information on the patient. I was going to ask Dr. Quesada
Oh.
about it.
Oh, okay. I don't know if we even have a shot at talking to her. I mean,
Yeah.
I mean,
You can talk to her.
Is she still in the hospital?
She's in the hospital. We're waiting for to transfer her one way or the other, or oncology, or here or there. I want to send it to their oncology.
Yeah.
To Memorial or MCI?
Well, she's been taken care by at Memorial, so you know.
I'll continue this.
They both talking to each other, and they're going to decide what to do with it.
Can we just write the story without the patient? Because I don't know in the condition that
you can write it. You can write a story without the patient.
Yeah, it might be go that way. It might be easier. She's still hospitalized.
Yeah.
But we got the fact that she's 62 and all her background. I think that's.
Dr. Quesada, is this kind of patient that you would then refer to the cardio oncology program, or not really, because the heart issue was not caused by radiation or chemo?
That is correct.
Okay.
It's a very interesting question. If the patient had radiation to the chest, it's an entity called post-radiation heart disease. And one of the things that radiation does, it produces valvular heart disease, calcify the valve, the aortic valve, the mitral valve, tricuspid, all of that stuff. And it's bad. Post-radiation to the chest. We see that in patients who had radiation when they were teenagers, like for Hodgkin's. They got massive radiation at the time. They developed 20, 30 years later, post-radiation a heart disease, which means valve disease. And those patients can have the same problem. In her case, this is not radiation related. This is related to a valve that was abnormal from birth.
Okay.
Right. Fantastic. Okay. Anything else we need to mention about this case?
No, I think the important thing is that this is a patient. Listen, what makes a difference is our center can take care of critically ill, very sick patients that in a community hospital in general, even though Memorial has an incredible cardiac program, and this is an example. I got another patient from Bethesda for another problem that they tried to do it, they couldn't do it, they sent it to us and we fix it. That happened last week too.
Right. Wow.
So this is what we are at tertiary center. Nobody knows about it. Everybody knows about it in our world, but out of our world, nobody knows about it. You know what I'm saying?
Right. Gotcha. And so what? And
that is a reputation.
What Dr. Fialco mentioned in his brief summary was it's rare because of the left main occlusion, the high risk left main occlusion,
right,
involving the native valve.
Valve.
Okay.
And important to mention, Dr. Quesada, that Dr. Moreno and Lopez Sanabria were both involved as well.
Yes.
Okay.
This is a case that needs a team effort.
Absolutely. Absolutely. Do we want to ask Dr. Quesada, Carmen, about the polyvalve?
Doctor, my polyvalve blog.
Remember that?
Do you think it's even good to write about it?
We can write about. Listen, this is a more advanced. It's a very advanced. This is the future of this field, and if you can. One of the problems with any valve, surgical valve or percutaneous valves, is durability.
Yes.
Okay. So with the new technology, anything that we can improve to expand the durability of these valves is super welcome, and we're going to get there. This is a very early stages. The polyvalve,
yeah.
Yes, it's in the very early stages, but like everything in life, changes occur in a very it's a process.
Right.
So you look at the valves today compared to the valves that were 20 years ago, they're totally different.
So this would be transformational for open heart surgery.
It will be transformation for everybody because the application will go expand. So the valves that the surgeons are putting today are different than the valves that used to put 30 years ago.
And the biological valves now can last, what, 10 to 15 years or more?
Yes.
Yeah.
Yes, more or less.
And what about like a compatibility for patients? Is that
because all these valves are already treated.
Okay.
And you're not going to have an immune reaction to the valve. They're inert.
Okay.
Okay, so you're not going to have a compatibility problem.
Okay. And how often, just for my knowledge, how often do you have to replace a valve?
If you put a valve in somebody in the 60s, you have to anticipate that in the early 70s you're going to have another valve. And then a third valve in the 80s.
Okay.
So this is now something that is going on. So what are we going to do with the very young patients? Are we going to put a TAVR, and then we'll put a second TAVR, and then a surgical valve, or you're going to do a surgical valve first, and then you do a TAVR, and then if he comes back, you put another TAVR.
Right.
This is a question that's still unresolved, on the go. So that's why, even the Europeans are very reluctant, and we are, to do TAVRs in very young patients because durability is a very important thing.
Right.
And second of all, if you do, if you're going to do surgery, then you have to remove that valve, and you have to remove two valves: the native valve that is there as an anchor, plus the new valve that you put in. And to do TAVR in TAVR, then the risk of coronary occlusion is higher. So all those questions need to be answered. We're working on it, but still we don't have answers.
And this study or this report that Carmen, I think, emailed you, they're estimating that this new polymeric heart valve could last up to 25 years.
25 years.
Of course, it'll be super welcome. It'll be like unbelievable.
Yeah, it would be.
Right?
But you have to.
We need to have real trials.
Yeah, that's the thing. It's really early. Yeah.
It's very early.
Yeah,
it's not even it's not even worth talking about it. To be honest with you, it's something that is okay. It's coming, but it's not here yet.
Right. Yeah.
Dr.
We have to do trials.
Can a patient choose between like a metallic valve or something? Can they choose the valve that they want?
No.
I don't think so.
Yes and no. So if a patient comes to me and says, I want a metallic valve, I'm going to try to convince that patient that you should not have a metallic valve because you're condemned to take anticoagulation for your life. And not only that, if the metallic valve goes bad, then you need to have a second operation.
Right.
So if I have to do surgery, I will try to convince this person that the valve should be bioprosthetic valve. Why? Because if the valve goes bad 20 years later or 15 years later, you still have the option to do TAVR, valve in valve. But if you have a metallic valve, that option is gone.
Right.
You have to take that valve out and put a new valve.
Okay.
So we're walking away from metallic valves. And there's some patient that, for whatever, I have a patient that is I'll give you an example. It's a very young man. It was in the late 20s, early 30s. I don't remember. A professional surfer.
Wow.
He goes all over the world, in Malaysia and stuff like that. And this guy, I would say, he needed a valve that was going to last long time. So I offered a metallic valve. But then I took the offer off because I said, my life is surfing. I'm going to go back surfing. So surfing means you're going to have to take blood thinners. You're going to bleed to death in Malaysia or someplace, who knows where, because you can't do surfing and take anticoagulation. It's like skiing. So in that particular patient, we put a bioprosthetic valve, knowing that in 10, 15 years, you're going to have to go back for another valve. And at that time, we have the choice of doing a second operation with this guy. because he's so young, and the third time he'll get tower.
Okay.
Okay.
So that's the thing, but we walking away of the metallic valves altogether, even though in certain cases that the patient are too young and they're willing to take anticoagulation for life, then you would say, okay, fine, let's put a metallic valve because the patient is too young. But today I don't remember when the last time I sent a patient for a metallic valve.
Okay.
By the way, how long ago was that surfer? Was that your patient? How long ago was that surfer?
A couple of years ago. I didn't do tower to this guy because he's too young.
Right. Okay.
I did, so we don't have durability. And the guy is a professional. Actually, the guy he lives now. He used to live in El Salvador. He moved to Canada, and he still surfers all over the world.
That's a good story.
Wow.
Yeah.
You should have operated on Mick Jagger.
Yeah, we're saying we should have done.
What happened?
So Mick Jagger. So that's an example. Mick Jagger said, "No, I don't want to have an operation," because at the time that he got the valve, the indication for him was surgery.
Really?
But it was a low risk.
Right.
Now, we have an indication for low risk for tower, but at the time that he got the thing, he was not.
Oh, I see.
So he went and said, listen, this is what I want. And some of the patients that we do internationally, that's what we do. If the patient comes here and he wants a valve, we say, yes, you're young. We don't have to deal with CMS or Medicare or none of that stuff. You get what you want. You want listen. If I do my decision, I will do the same thing. Why should I get my chest cracked?
Well,
yeah.
When he
I
needs
can go home in 24 hours.
He's probably going to still be rocking in his 90s. So when he needs another one, we'll come back to you.
Have you seen this guy? I went to this concert, man. The guy looks unbelievable.
You did?
I did.
Yeah.
Well, I did a long time ago, Doctor. Back in '89, I went to a Rolling Stones concert. They've been doing that for years, man. Anyway, he's incredible. Anyway. Bioprosthetic valves.
I went to the last one here in Florida.
You
I
did?
couldn't believe that this guy is,
Fantastic. Yeah.
Say it again?
No, you went to the last concert in Florida?
He already had the bioprosthetic valve.
Yeah, fantastic. Oh.
That's what I'm saying. I couldn't believe it.
I know.
The guy was like, wow.
Yeah,
It's
fantastic.
unbelievable.
I know. Bioprosthetic valves, does that require blood thinning medicine for the rest?
No
blood thinning.
Metallic valve required for the rest of your life.
No requirement.
Metallic valves.
Only
yes.
metallic valves. All right, sir. I think I'm good over here. Anything else, Carmen? You want?
Yeah. No, I'm good. Can we do, John? Do you have enough to make the polyvalve one and this one?
Well, I don't know if the polyvalve is worth. A whole lot. It's so early,
You can
right?
mention it, and you think that durability is an issue with surgical and towers, and we have new research that is new development.
That's promising that
It's
shows
promising.
the valve will.
That's all it is with that valve. Promising.
Yeah.
We don't know much about it.
Promising.
Yeah.
I should write it.
You'll grab anything to write an article.
No,
It's a little All right, Doctor.
Alrighty, okay.
We'll email you
Take
with any
care.
questions. Thank you so
Thank
much.
you. Bye, doctor. Bye, John.
Bye.
Take care.
Bye.
Bye-bye.
Oye.
Dime. Oh yeah, you'll grab onto any story. You know.
I love him. He's just the best.
He is. Yeah.
When you get him, he has a lot of good information.
No,
I
he
mean,
does.
it's hard getting him down. But
He's actually, once you start talking, he's very quotable. You know.
yeah.
He's,
Okay.